It's fair season across Vermont, and if it can be dipped in batter and deep fried, it's probably on the menu at a county fair near you, which makes this the perfect time to talk about cholesterol. New guidelines are out, and we're talking about the impact on your heart health today on Across the Fence. Hello, Vermont. The first time a doc noted my high-ish cholesterol, I was in my 20s. No real worries, they assured me. My bad LDL was on the high side, but I also had a lot of HDL, which is the good cholesterol. And I was young, fit, and healthy. That message remained the same throughout my 30s and 40s, and then I turned 50, and statins entered the conversation. So, what changed? Sure, I'd aged, but was I no longer healthy or fit? Had my risk gone up? I had a lot of questions. Still do, which is why I am so pleased to welcome my guest today. Joining me is Dr. Kramer Wahlberg, a cardiologist and assistant professor of medicine at UVM's Larner College of Medicine. Dr. Wahlberg, thanks for joining me.
Excited to be here. Thank you for having me.
Yeah, and I promise you this is not actually where Amy is like, this is my doctor's visit, and I'm going to now ask him all of my personal questions, but I figure I can be the foil for the audience and say, use me as your guinea pig and my case history in order to have someone to talk to. But let's start with the basics. What is cholesterol and why are we even talking about it?
Yeah, no, it's a great place to start. I think when we talk about cholesterol, like when you go to the doctor and have your cholesterol drawn, we're talking about the amount of cholesterol that's floating around in your bloodstream. We care about it because we know it's one of the major risk factors for the development of cardiovascular disease or the risk of heart attack or stroke. And we know, for example, certain types of cholesterol, like LDL cholesterol, are really causal in why folks develop cardiovascular disease. And so for some people, lowering that cholesterol might make sense to lower their risk.
Yeah.
And 1 in 4 people, for example, have elevated cholesterol. So it's a big issue that's out there.
You just said LDL, and I said LDL and HDL. So I, like the teacher in me, says, let's go back and define our terms. So what's the difference between LDL and HDL?
Yeah, great question. I'll try to break it down as simple as possible without using any complicated words. But so cholesterol floats around in the bloodstream in particles. It's not really dissolved. It floats around in these particles that are wrapped around with a protein, and we call them lipoproteins. I only mention that because the word LDL means low density lipoprotein, and HDL is just a different type. So not all cholesterol is capable of causing harm. So the way cholesterol causes cardiovascular disease is slowly over many years and decades. The cholesterol can get into the walls of the artery and cause cholesterol plaques to develop and potentially even make them at risk for those plaques breaking open and causing a heart attack or stroke. When we measure your cholesterol in the office, for example, you get the total cholesterol and then you get different types of cholesterol, the HDL or the LDL. Yeah. So HDL has often been called the good cholesterol. Where that sort of comes from is that HDL, as it turns out, is not responsible for those plaques forming. Whether a really high HDL is actually protective, I don't know if that's necessarily true, but really what we want to avoid is the HDL being very low. That's a risk, a marker of risk. So it goes along with being metabolically unhealthy, with excess weight, diabetes, those types of things. If we take your total cholesterol and take out the HDL, everything that's left, those are the types of cholesterol that can put people at risk of heart disease. And LDL is the vast majority of that type of cholesterol. And so that's why we tend to look at that. And in the clinical trials that have been done, LDL has really been that marker that we look at in terms of when we give somebody a treatment, for example, how do we lower the LDL? And depending on what someone's risk is, we might recommend their LDL being brought down to a certain level, for example. So.
And HDL and LDL, so how much of this is a relationship to diet and exercise?
Yeah.
Because people will have heard things about like the Mediterranean diet or eating oatmeal, different types of ways that you can use your behavior in order to influence your cholesterol. How effective is that, or do we always have to go to medication?
Yeah, absolutely, great question. I think the foundation of prevention as a whole, and prevention is really comprehensive. We're here to talk about cholesterol, but I think it's just one important risk factor, right? Yeah. But the foundation of all of this is a heart-healthy lifestyle. And I think for most folks, a heart-healthy lifestyle, diet, as well as regular exercise can go a long way. Heart disease takes many years and decades to form, but it's cumulative kind of exposure to high cholesterol or risk factors. Yeah. That being said, there are some situations where maybe that's not enough. So for example, 1 in 250 people are born actually with a hereditary form of high cholesterol. You don't feel that until maybe in their 30s or 40s, they come in, for example, with a heart attack or stroke. So that sort of speaks to maybe one example of why screening and early recognition and treatment is so important, and that's why, for example, teenagers are getting screened in the pediatrician office. And so to answer your question, I think lifestyle is the foundation, and for many folks it may be enough, but for some people, if their risk is high enough, then we may, that's where medications or other treatments might enter the equation.
Well, and then let's stick with risk, because when you and I talked, actually, it's really also eventually all becomes about understanding your risk profile and what's driving your risk individually as well. Like mine, my LDL is just always stays a little bit on the high side, and I eat pretty well, I exercise, so that's the reason why we got to the place of saying, let's try a statin. The other contributing factor, though, was LP(a).
Oh, yes.
So tell us a little bit about what that is.
Yeah, so LP(a), the sort of long word, lipoprotein(a), it's getting a lot of buzz. It's actually something we've known about in the medical community for a long time, but in recent years, I can just tell you from my own personal experience, as well as just what I see out there in social media, it's really kind of percolating through. A couple of reasons. One is, I think we know more and more about that it is a really enhancer of cardiovascular risk, but also there may be potential treatments on the horizon. And the new guidelines that you mentioned really actually emphasize lipoprotein(a) a bit more than in the past. So what to know about it? So like LDL cholesterol, which we sort of identified as a type of cholesterol that is capable of causing cardiovascular disease, LP(a) is similar to that, but there's some unique features. It's like LDL, but it's got this a sort of protein around it that makes it unique. It's very potent at causing plaques to form and making those plaques at risk of causing a heart attack. But there's two sort of important characteristics. One is it's largely determined by your genes. So 90% of whatever your LP(a) will be is determined by your genetics, and it it reaches that level early in life, and it stays relatively constant throughout the course of your life. So we talked about how cardiovascular disease takes many years to form, right? So if somebody is exposed to a high LP(a) early on in life, that, for example, could explain why someone comes in with an early heart attack or stroke than we might otherwise see. So the genetic component is important. The other piece is we just got done talking about how we can lower LDL with either lifestyle or medications.
I know this is the big bad kicker on this one.
Yeah, we unfortunately don't really have a meaningful way to lower it right now. So the best lifestyle in the world or our usual treatments can't really lower LP(a). So the current way we think about it is we know it's a powerful risk enhancer, and I think it's a valuable piece of information to know. So if somebody has a really high LP(a), we acknowledge maybe we can't lower that right now, but that gives us even more emphasis on trying to identify and modify any of those other risk factors that are under our control. So maybe for some folks that's stopping smoking or, of course, better lifestyle. But another thing that we often recommend is, let's say somebody has a high LP(a), but also has an LDL that's kind of high. If we can't lower the LP(a), we might lower that LDL more than we otherwise would to try and offset that risk. And there are some treatments that are being investigated. So none of these are FDA approved. There are investigational treatments that have been shown to lower LP(a). However, those have just been studied in early, phases of clinical trials. Currently, multiple are in sort of later phase 3 clinical trials. Of course, we hope they'll be helpful, but I think, like many things in medicine, we're often surprised. Something that sounds like it would help, we don't really know if it will help until we actually study it in folks and understand if giving people this treatment will actually lower their risk of heart attack or stroke.
Let's stick with that idea of risk enhancers. Because I thought that was interesting. And so along with the new guidelines, we also talked about this idea of CPR, which is not in this case going to actually be the CPR that you are thinking of. But tell us what CPR stands for and how that helps docs assess your individual risk and then design almost like a more personalized treatment program for a person.
Correct, yeah. These new guidelines, they sort of take what we've been doing historically and sort of take it, a little bit more and give it this CPR framework, which stands for calculate, personalize, and reclassify. So I think let's just kind of peek under the hood and think about if we were in the office talking about your risk, and how do we make that decision about what we should do? So the first step is we try to estimate what your risk of having a cardiovascular event is. We have these validated equations where we punch in your data, your age, your blood pressure, your cholesterol, all these factors, and it sort of says, based on thousands of patients who are similar to you, what would be the risk of something happening? And you sort of categorize into low, intermediate, or high risk. Folks that are low risk generally don't need any treatment. Folks that are high risk often do. Folks that are intermediate or in the middle, sometimes we have a conversation about that. And then the personalized piece means we then add on any risk enhancers, so say lipoprotein(a), a family history, certain ancestries, other things that can further enhance that risk and sort of personalize it to you.
Yeah.
And a big piece of that too is talking to patients and figuring out what's important to them. Some people really are maximizers who want to have everything done. Some folks are minimizers. Most people are kind of somewhere in between.
Yeah.
And then the last piece, reclassify, is sort of incorporating all that and figuring out, okay, we have all this information. What really is your risk and how should we go about doing it? Sometimes there's other testing that comes into the equation, such as a coronary calcium scan or a calcium score. So that's really what it comes down to.
Yeah. And what's interesting, so that's where I was in the middle ground. I was in the middle ground. I have sort of this high-ish LDL, and then on top of that, I did get my LP(a) tested, and it turned out to be my number. I don't need to say what the number was, but it was twice what the upper threshold is for saying you're fine. So at that point, started on statins. And I will say that, you know, statins are I was hesitant because I didn't like the idea of taking a daily medication, but for people who are in that same boat, what should we know about statins?
That's a great question. So there's, I'm happy to talk about that, and there's a lot out there that's on statins. I would say when it comes to statins, they're one of the largest studied, you know, medications in medicine and cardiovascular disease in terms of the number of patients that have been studied over the years in clinical trials. And we know that they're safe. We know that they can, some folks that take them can certainly experience side effects, but it's complicated. In some of the clinical trials, the same amount of folks that took the placebo as the study drug experienced side effects. And there's been more studies that have tried to tease this out. So it's complicated. You know, I tell people, you know, what the rate, for example, of experiencing side effects could be, and I also explain, you know, try to have a transparent conversation about this. But one thing we do know is that they are effective in lowering the risk of cardiovascular disease, both for folks in sort of the prevention setting, as we're talking about now, but also in people who have had a heart attack or stroke. And so they tend to be our first line medication because we know that they're safe and we have a really strong evidence base.
And I will say that, you know, it's been a real absolute nothing burger for me, you know, and it was more a psychological barrier for me to get through. We only have like a tiny little bit of time left. You can talk to your primary care physician about this, right? You don't have to go and see a cardiologist. You and I were talking a little bit ahead of time. Your wife is even a family care practitioner, and so talk to your primary care physician. They are very well situated to help you. Last question. What is the best resource for people who want to know even more about protecting their cardiovascular health?
Yeah, I think it's always good to go to a resource that you can trust. And there's a lot of information out there. I really like the American Heart Association. Their website is heart.org. They have this program, what they call Life's Essential 8, which really talks about those important cardiovascular risk factors and behaviors that really, you know, that we can focus on to lower somebody's risk.
Yeah.
And if you go to the website, there's a lot of information, really great infographics that are easy to read. If you're interested in diving deeper, like say on lipoprotein(a), that's there as well.
So you can figure out if you are a maximizer or a minimalizer yourself, get some great information about all of these different types of things that you can do. Some things you can't control, some things you can. And I guess that's always, what is it? The wisdom is knowing the difference between the two. Yeah. So Dr. Kramer Wahlberg, thank you for joining me today.
Thank you for having me.
Appreciated it. And as always, thank you, Vermont, for learning and exploring with me today. And thanks to the team that makes Across the Fence possible. I'm Amy Finley. This is Across the Fence. Come back and let's learn and explore again tomorrow.